rather than good evening, each and everyone. And I'm going to talk about the biologics, biosimilar, and biobetter, which is kind of area of interest globally. And we have been trying to understand these molecules since last 3 years. And this is our contribution in the form of publications that we had related to any biologic and the biosimilars in the last couple of years or so. So I would like to acknowledge all the faculty members and our colleagues across the globe who have been helping us to understand these molecules in the last 2 to 3 years. And I would like to especially acknowledge two of my residents, Dr. Nilesh Kumar and Dr. Nicola Parachuri, for helping with all these publications a lot. So I do have financials to disclose here because it's an INTAS program and I have consultancy for INTAS. So this is the first paper that we published in 2019 March. And we asked the question that whether biologics, biosimilars, and biobetter, these different terms or are these different drugs? So essentially to say that all three are different entities because they go through a different kind of regulatory pathway with subtle differences. And biologics, if you just talk about the biologics, as per the EMA, which is the European Agency of Medicinal Product, it defines biologics as any medicinal product that contains biologically derived protein as an active substance is called biologic. So biologics essentially, they need to involve some kind of living organisms in their process. So that's how they are extracted. So that's where, protein differences, it exist. So if you look at the biologics, means you can find biologics in your day-to-day, scenario, clinical scenario. For example, easiest to point out is insulin. But if you really just want to talk about biologics as in the retinal practice, we have 4 molecules that we have been using since last 10 years. Avastin, Lucentis, aflibercept, and the new kid on the block is brolucizumab. At the left-hand side of the slide, if you look at, this is the classical structure of any kind of monoclonal antibody, which should have FC portion at the bottom and the FAB portion, which essentially is used for the antigen recognition. So what happens is, this is the structure which can be played upon, and that's what the companies are being doing by changing the structures. And with each change, you can have differences in terms of the molecular efficacy, even the molecular weight. For example, if you look at the the classical monoclonal antibody structures having all the light chains, heavy chain, FC portion, FAB portion. But if you look at the aflibercept, it has a little bit change in the FAB portion with the decoy receptors, but FC portion exists. However, in the other 2 molecules, in Lucentis and in the brolucizumab, you have absence of FC portion. Absence of FC portion can lead to various advantages and disadvantages. Primary function of FC portion is to provide stability of a molecule. But as a molecule, keep getting smaller in the size, you can have folding differences in different kind of molecules. So look at the different sizes of all these molecules. And the newest molecule that we have, brolucizumab, is the smallest size molecule. And the smallest size not only in ophthalmology, rather smallest size molecules have ever been made in medicine. So biosimilars, if you talk about, biosimilars are essentially molecules which are kind of similar to the biologics, which are already approved by the FDA and EMA. What they need to show is they need to show similarity in terms of safety, purity, potency. They can have they can have differences which are not clinically meaningful because they cannot be the exact copy of the biologics. Why is that? Because they do not get the entire information. Whenever they get the product, so they need to do a reverse engineering. And the example of biosimilar is Resumab, which is the biosimilar of Lucentis. if you want to see more update what is happening on the biosimilars, you can refer this paper which was recently published. So essentially, sometimes, if you are not going deeper into the details of biosimilars, they are sometimes get confused with the generic drugs. But generic drugs are basically, if you look at the left side box, chemical formulas. However, biosimilars, they come from the living organisms. So the process of manufacturing is pretty complex as far as any biologics is concerned. However, chemical formulas, for example, ibuprofen, you must be knowing that ibuprofen, you can have many brands of ibuprofen and they can be manufactured in the common, simple facilities. Now, the question is why actually you need biosimilars? Essentially, the one benefit that biosimilar provides over the innovator molecule is the cost benefit. And how can they do that? Because reference biologic takes approximately 10 to 15 years with an investment of approximately 1,200 to 2,500 million USD for a single molecule. However, biosimilar can cut down the years up to 8 to 10 years with almost 1/10 of the investment that innovator biologic does. So that's why they can provide cost benefit ratio, but you cannot say that that can happen like generic drug, because essentially they also need to spend a lot of money. That is why all companies cannot get into the biosimilar development. This was my question when biosimilar was approved in India, that when can biosimilar enter in a country for its use? Because my question was, if you already have the your proprietary rights, then how can you come before even a decade? So each and every regulatory works in a different way. How India works is, if any drug which is not being used in India and it is being used and shown safety and efficacy data for 4 years in any other country, you can go ahead and manufacture those drugs as a biosimilar. So this is as of now, Resumab is only approved in India. It has not yet gone outside India, and there is no biosimilar in ophthalmology, especially in the retina practice, which is approved by the FDA or EMA. And I know that Intas is trying to get approval. They are into their trial. So first candidate, what you could see in future as biosimilar or ranibizumab, which is on the verge of approval, is SB11 by the Samsung Biopsys and the Biogen collaboration. And recently, Dr. Neil Bressler, he was a lead investigator for the trial. They published the data on SB11 phase 3 trial. And we had some questions in terms of, because there was discrepancy in terms of the endpoints, the primary endpoints for FDA and for the EMA. Dr. Neil Bressler had answered all our questions, but still we had some of the communication going on with the FDA evaluator, who is going to clarify that how these two evaluating agencies are different in terms of the biosimilar approval process. You might see that paper very soon. And as I was mentioning, that biosimilars, they have a different kind of approval pathway. That's how they save money. And this was the paper, which we published, that how the various aspects of the approval pathway is different, because ophthalmology is experiencing this biosimilar as a new entity. So people, even at the higher level, are not aware about the approval process. So essentially, if you want to simplify it, these are the two pyramids. One is upside down pyramid and one is normal pyramid. So normal pyramid, at the baseline, you have to have the analytical data to show the bioequivalence, and you need very little information about the clinical trials. That's how they save money on the clinical trial, most likely, and they could pass the benefit. So entire world can take confused from India in terms of, am I audible?
Yes, go ahead, Dr. Ashish.
Okay, so entire world can take cues from India, from the experience of India, because we are now experienced more than 6 years. And these are the couple of papers that we published, and especially I would like to highlight that education plays an important role for biosimilars, to be used effectively, because there's a lot of nocebo effect goes around these drugs because they are not copy of the innovator molecule. Biobetter are the molecules which are related and quite similar to the biologics. And what happens is sometimes some molecules, they do not perform the way they were designed. So if you want to improve upon them in terms of the safety, efficacy, and the other aspects, you can change a little bit, and you can again go them for the approval. But the problem with Biobetter is, as of now, FDA and EMA considers them as a new molecule. That is why you do not see a lot of companies, they have interest in labeling them as a Biobetter. And interesting fact, I think you would like to know that Lucentis was actually not a new drug. Lucentis was actually a Biobetter of Avastin. They have cut down the FC portion, and they have cut down the one arm, and that's how it became better, a smaller molecule, which could have penetration in the retina. And as of now, what we are seeing with brolucizumab, things are not going in the right direction with a new kind of adverse event. What we propose is Biobetter could be the future of brolucizumab. We do not know whether company would come and label it as Biobetter or as a completely separate molecule. That is the thing for future. Thank you for listening, patient hearing, and this is the teamwork from all the residents and the entire group. Thank you very much.
Thank you so much, Dr. Ashish. In fact, Ashish, if you remember in the VRSI conference when I first presented the biosimilar,
I was the strong critic.
Yeah, you were, and no, let me complete. So Dr. Ashish was such a strong critic that he was just bombarding me with the questions and the question. And I'm so happy that he has taken it so much forward. And in fact, he is the man who is now working more on biosimilars. On the contrary, when he was bombarding me with the questions in VRSI. And I still remember one of your questions, Dr. Ashish, that why this trial was not done in the rhesus monkeys. Can you then later on, of course, I told him that I'm a clinician, I'm not a scientist, and later on I got to know about that this need not be done in rhesus monkeys is because it's a biological product. If you have to do a phase 1 and phase 2 trial, that is where the bigger animals are required. Otherwise, for already approved drug for the biologics to be happening, we don't require the rhesus monkeys to be involved into the trial. So we have our panelist, Dr. Raja sir, also here. Yes, Dr. Raja sir, any comments on the beautiful presentation by Dr. Ashish?
The only beautiful comment which I can make is Ashish has done a tremendous job from India. He has been a torchbearer not for India, for the entire world in this field. Overall, I would say that biosimilars definitely have been an important addition to the world. If we cannot just be presenting in conferences, I gave 3 or 4 Lucentis or Eylea and X number of patients improved. But what happens to the 10x number of patients who are not being treated or unable to get treated? And in that context, both biosimilars, which are cost effective and also safe. In terms of safety, we definitely need to evolve more in terms of how we can make those assessments, as Ashish has also worked on it. How should FDA, what all should it look at, what parameters they should look at? And when we say FDA, right now it's US FDA, but at some point, even the Indian CDSCO, we should be able to guide them and tell, okay, these are the things which we should look at for biosimilar approvals. And if you do this, then we won't have setbacks in the future.
Actually, sir, I mean, sorry to interrupt you. What has happened, recently? If you look at the SB11 data, which trial Dr. Neil Bressler was heading. If you look at the primary endpoint, they had 2 primary endpoints. One is the BCVA, one is the CMT. And BCVA is for FDA and CMT is for EMA. So that was our question, that why these 2 regulatory agencies are differentiating. And then we wrote editorial which was rejected by the ophthalmology. And now, in ophthalmology, we received a reply from editor-in-chief. He said, we have sent this to a person who deals with from FDA. It was rejected, but then a person who deals with FGA, because Cooperman was co-author, he called Cooperman and he said, you know, the information was so important to clarify that I want to correct that paper. And I want to make sure that that goes in public domain. So we will know that in terms of regulatory aspect.
Good. Thank you. We have Pramod Bente sir also here. Pramod sir, are you there? Because he said he'll be coming in between. Now, quick question. We have under 2 more minutes before we go to Dr. Chakrabarti. Pramod sir is here. Sir, I have a question to all of you here. Can you see this? This was the thing which was given to me. It is called as Vizumab by Cipla.
Yes.
And just 2 days back, it was given to me. Now, Dr. Ashish and Dr. Narayanan and Dr. Pramod sir, please tell me, as a vitreoretinal surgeon, now which one to use, which not to use. And Ashish has said that, yeah, it is the Razumab which has the Indian authority. But this doesn't have an Indian authority, then how can they go in for this thing?
So how does it not have Indian approval? It has Indian approval. Otherwise, they can't go to the market.
Yeah, they cannot go to market unless they have a drug controller's approval.
So if you know, even the drug from the Reliance Ranitidine is also there. So when I was writing this American Academy paper review, I had the same question from them that, you know, I want to include this, but until unless I have some proof on paper, I cannot refer it. So then they showed me a letter from the DGCI, where DGCI has recommended that, you know, we need this data more to give the final approval. But they started marketing it before that itself. So I think the same thing is happening with Cipla.
Sir, Pramod sir, your experience in biosimilars in SN?
Yeah, because we have, I think, a great experience, and we are limited with the Razumab only in task. Because other biosimilars slowly are coming in the market everywhere now, and this, as you said, Cipla is coming up, Samsung is coming up, Reliance Lab already in the market. They are behind us to have their thing with us. But the same thing, but as far as limited experience was with the Intas Razumab, I think experience is great. And it's equally effective with all other. Yes, we had a hiccup in between, and all of us, we all know that the toxicity, a little bit exaggerated inflammatory response. And I think they have sorted out that part very well. And I mean, now current practice is we give option to the patient, whether you would like to have Razumab, whether you like to have Accentrix or Eylea, patient chooses. Of course, Avastin was in a armamentarium as well, but because of this COVID situation and because Avastin has to be shared, right now we are not giving that option to patient because of obvious reasons. But yes, there's no bias. We let patient choose what he would like to have depending on his affordability. We are equal for everything.
Thank you, sir. Thank you.